I'm Dr. Michael Miyasaki, and it's great to have you here for part two of this endo-resto case that we were discussing. And I titled this "Getting Out of the Gray Zone" because I know there's people that sometimes him and ha over them doing the endo and the resto, and I just want to get you back on the colorful side of dentistry because I think being able to do the endodontic procedure and the restorative procedure is such an advantage for both the patient and your practice. So, just a quick reminder where we were. We were working on a female patient, about 70 years old, in good health. Her chief complaint was on the lower right-hand side, there was some growing discomfort. It had been going on for about 2 weeks, and certain nights it got so bad she was having to take over-the-counter pain meds. We went through last time about how we figured out which tooth it was. It was the lower right first molar. We did radiographs. We tapped on the tooth. We had her bite on a tooth sleuth. We probed around there looking for a fracture, and then we did our cold test. And it was really the cold test that zeroed me in that something about that lower right first molar, the pulp just was not healthy. It gave us a delayed response to cold, and this wasn't acting healthy. And I told the patient before we got in to do the root canal that it was my bet that once we got in there that there wouldn't be a lot of bleeding, that the nerve, in my opinion, had kind of gone kaput, necrotic, had died. And as we got in there, we would just be cleaning out the tissue, maybe some infection, and then sealing everything back up. So during the last program, we talked about how we discussed the treatment and the finances, and the patient gave us the go-ahead to start. So here we are. We're going to do the root canal. And if all these steps don't mean a whole lot to you, maybe go back and look at some of our other YouTube programs, because this is just kind of bringing everything together. I'm just going to go through this really quick, and maybe you can pick up some tips here and there. So we're going to do the root canal treatment in our practice. So what I do is I numb the patient up first. Two cartfuls of 1.8 cc, 2% Lido, 1 to 100,000 epi. Nothing fancy, just my inferior alveolar nerve block. So I give the patient the anesthetics. I give it a little bit of time, maybe 5 minutes. Let it get really good numb so the patient doesn't feel anything in their right side of the tongue or the right side of the lip. And I touch back there to make sure that everything's comfortable. What we're going to do is we're going to do this as a one visit, but two-step. We're going to do endo and then the resto. So I prep the tooth for our crown, and we do our intraoral scan. And when my assistant takes that scan and starts designing the crown, I then go ahead and do my opening into the pulp chamber. I measure from the top of my occlusal reference point, wherever that may be, down to where I think the top of the pulp chamber should be, and then from that occlusal reference point where the floor of that chamber is, so I don't perforate through the floor of the tooth. And so I know about when I'm going to break into that chamber, and then I know that I don't want to go too far further down than what I estimate the distance from the occlusal reference point to the floor of that pulp chamber is. In this case, I've adapted. I've used a few different endo systems. The one that I'm using right now is Coltines. They have a lot of different file systems out there. I treated this with their OGSF system. O is just kind of the opener. Then we have the glide path file. Then we have the shaping file. Then we have the finishing file. And they work off of their X-Move motor. Now, the X-Move motor is just a little handpiece, but it's a great little handpiece because it's a built-in apex locator, and it's very easy to use. So that's the file system that I used with this case. So I get in there, and I get into the pulp chamber. I get in, and I find the canals using my little endo probe. And then a number 10K file, and I just make sure that I can get into the canals. I don't have to get all the way down. I just want to make sure I can get into a canal. So then step number 5 is I put the rubber dam on. Now you might say, well, why didn't you put the rubber dam on when you started? Well, for me, when I put the rubber dam on, and if I only have one tooth exposed, it's harder for me to tell the orientation of that tooth, and I'm just more worried about perforating out a side of the tooth because it's hard to see the orientation of that tooth. When I have all the teeth there, if I can see the second molar, I know that if if the first molar, hasn't been moved or rotated in any weird way, that I have the orientation of that first molar, and I know how to position the drills and make my access into the first molar chamber. And then I'm testing my anesthetic, because if I get into that chamber, or if I'm working on the tooth, getting deeper and deeper, and the patient says, I'm starting to feel that, then I just add more anesthetic. But for me, it's harder to add the anesthetic when I've got to work around the rubber dam. So what I have found that works for me, and yes, I have to be careful with the one file that I use, is that I will do my access opening and most of the time without the rubber dam on. And then I'll just confirm that I found the canals. And when I've done that, I know the patient's numbed up. So then I put the rubber dam on, isolate that area really well. Now I go back in with the X-Move motor and our opening file to establish the orifice in the canals. And so I just go in there, and now this is a more aggressive taper, but we're not trying to go down to length. We're just trying to open up the orifice. In the past, I used things like Gates Gliddens, but these are going to be a lot more conservative than a Gates Glidden. And I just established the access opening, just the orifice part. We're not going down beyond even the curve in the root if there's a curve. So as I do this, I might use a little lubricant to get the files down there. Then I'm using a lot of sodium hypochlorite irrigation, both to disinfect and dissolve the tissue in there, to kind of suspend any of the dent and mud, and then to help me clean that canal out. Now, from some of the past programs, we've talked about the irrigants that I use. Because these file systems move so much faster than when we had to hand file everything out, I need irrigants that work faster. So I use Chlor Extra. It's a more advanced irrigating solution. It's sodium hypochlorite, but remember, this sodium hypochlorite has surfactants in it that helps it disperse into the lateral canals, and it helps to dissolve tissue faster than straight sodium hypochlorite, either in the 3 or 6% solution. So I'm opening up the orifice, I'm getting my access into the canals. I'm using a lot of the sodium hypochlorite irrigation to make sure that we're not packing debris down into the apical area, that we're suspending and rinsing it out. I repetitively will use the number 10 K file just to ensure that we have patency as I work my way down, just to make sure that we don't pack anything down or that we don't push material out beyond the apex. I then would go into the next file, which is a glide path file, again with a lot of sodium hypochlorite. Now as I'm working my way down with the glide path, that file will begin to work its way down to the apex. And so as I take that motor, I'm kind of pecking my way down. And when I get to the apical third, if I get any binding down there, sometimes there's a little constriction, so I'll just go up and down, and then I'll stop. I won't force the file down there, right? I'm just pecking maybe 3 to 5 little pecks, and I come back up, irrigate out, put the file back down there, 3 to 5 pecks, then I irrigate it out, 3 to 5 pecks, and then irrigate it. And typically when I go back in, maybe that third or fourth time, now it just like will slip past that constriction because we've opened it up, and then I irrigate it out. So it's just really light pecks. We're not forcing it down. One of the things that I know, we all get impatient and we want to force it down, but if you force it down, and it doesn't have to be with these file systems, any file system, if you force it down, it could separate. You could have a file break, and then that's going to take you a lot longer to correct. So just take your time. Take a deep breath and just do a little pecking. Just takes 5 seconds. 1, 2, 3, stop. 1, 2, 3, stop. When you're stopping, you're just irrigating, and then you just keep going, and then it slips through. When it slips through, that's when you kind of sigh relief that, okay, we're past that. That's probably the hardest part now. So with my little X-Move motor, it has the apex locator on the motor itself. So as I'm going up and down, I can see where I get to my working length. Once I get to that working length, if it looks like a good reading, then that's going to be what I'm working to. Now, sometimes, like with this case, the working length was only, from my occlusal reference point, was like a 13. I was thinking it'd be like more around 18. And so I wasn't sure if I should believe it. So what I did was, every time I got to that 13, the apex locator said, hey, you're there, you're there, you're there. I was like, but I think I need to go further. So I did stop at one point. I put some files in, at 13, 15, and I took a PA, and I could see that at 15 I was a little bit long, and this was just with 10, 15 files, so it was okay if I was a little bit out the apex, but it showed that I was a little long, and the 13 was the measurement to go for. So once I was assured that 13 was the measurement, then we just kept working that system. So now I go to my S file to shape the files, again with copious sodium hypochlorite irrigation. But now because we're getting to about a 25 file, then I use the activation, which again, we've talked about in other programs, is my Endo Ultra, my ultrasonic activation. I put the tip down there into the irrigant, and it's going to mix everything up, right? So I'm mixing everything up, I'm getting rid of all the debris, and I irrigate. Then I go back in there for maybe 5 to 10 seconds with my Endo Ultra, going up and down with that tip, and then I irrigate again, and you will see the mud. You'll put the Endo Ultra into clear irrigant, and when that Endo Ultra hits there, it stirs everything up, and it'll just get cloudy. And then you rinse it out, and it'll be clear. Then you take the Endo Ultra down there, and it'll turn it cloudy. Then I just repeat that, and then now I know my working length. I've irrigated very well. And now I go to the file, the finishing file, again working towards that working length with copious sodium hypochlorite. So now I've got my working length, I've got my finishing file working all the way down to that working length where I want to be. I've been rinsing everything out, so the sodium hypochlorite is dissolving in your tissue. It's disinfecting the canals, but we're creating this mud, and that mud gets into all those dental tubules. And so what I then do is I use EDTA. EDTA is like using phosphoric acid before you bond composite to a tooth. So when we prep a tooth, we have that smear layer, everything on top, all the dust, all the bacteria that sits on top of the dental tubules. Now, when I place my composite, I need to get into those little tubules to get my resin tags. So what we do is we put the phosphoric acid down there and rinse that off, and the smear layer is removed, and the dental tubules are opened up. So then I can apply the adhesive, which then penetrates into the tubules and helps give us our bond strength. Same thing with our EDTA. With the EDTA, we're going to rinse, activate. And what we're going to do is we're going to open up all the little dental tubules, all the lateral canals along the root canal system. Then I'm going to go back in with sodium hypochlorite. Why? Because the sodium hypochlorite can now penetrate into those lateral tubules and anastomoses and disinfect that. And if there's any tissue, get rid of that tissue. Because remember, our files do not instrument all the walls. We miss a large percentage of the walls. So the actual cleaning is actually more dependent, I feel, on the irrigation and the irrigants. The files open up the access, it shapes so we can obturate, but the files don't hit all the walls. And so we have to use the irrigants to disinfect and clean out the tissue. So we do that. Right about now, our crown was done. So I took the rubber dam off. I tried the crown on. I checked the contacts, mesial and distal, had the patient tap, checked the occlusion. Then I gave the crown back to my assistant, who then got it ready, glazed it, and sent it up into the oven. That gives me about 18 minutes to finish this up. So had all the filing done, had all the irrigation done. Now I take my gutta percha, like number 25 gutta percha points, and I put those into the 3 canals in this case, and had my assistant take a PA just to confirm that we had good placement and we weren't too long or too short. What I then do is irrigate the canals with some sterile water just to rinse everything out, the sodium hypochlorite that we use at the very end. And then I use paper points just to dry the canals out. Now the canals can be moist because that moisture will help our bioceramic sealers actually set. So we don't have to get super dry, but I just don't want a lot of water in there. So a little paper point, just quickly absorb all the excess moisture, get a new paper point, go into the next canal, sop up the extra moisture, put that aside, and then do the same thing in the 3rd canal. Now, the sealer that I'm using is a Regen Bioactive Endosealer. Why? Because it has the bioglass in it. The bioglass is going to help that tooth and the bone heal up. It's going to create a very alkaline environment. So even if I overfill, if I were to get a puff on the outside of the tooth, because it's not acidic and it helps create a more alkaline environment, it's not going to create postoperative pain. So I found this to be very successful. So I really enjoy using the Regen Bioactive Endodontic Sealer. The way I learned when I was in school was we did lateral condensation. And the reason why I did that is back in the day, our sealers would shrink. And so we were trying, like when we do a composite, we do incremental buildups when we do a large composite because the volume will shrink up. So we don't want a large volume to shrink. We want a small volume to shrink if anything is going to shrink at all. So same thing with our gutta percha. In the old days, our sealer would shrink up. So we wanted to fill everything up as much as we could with gutta percha so that the volume of sealer was small. So if it did shrink up, it wouldn't have a large clinical impact on our root canal. Today, especially the Regen Bioactive Endo Sealer, there's not much shrinkage at all. It doesn't dissolve. It's going to harden and give us a good seal. Today, the gutta percha is there just to kind of push it down all the way, gives us a little hydraulic pressure to move it out laterally. And it gives us the ability to then go back in there at some point if needed to retreat that because our drills and files can follow the gutta percha. But I'm using the Bioactive Endo Sealer. Now, the Regen Bioactive Endo Sealer is actually price-wise very reasonably priced. But there are some bioceramic sealers that are really expensive, so you don't want to waste this material. So we're using an MST visco tip. It's a material saving tip where as you express the bioceramic sealer out of the syringe into your delivery cannula, you're not going to waste a lot of sealer in the hub. So the MST hubs are designed where really just the sealer goes from the syringe down into your delivery cannula needle, and there's very little waste. So using MST tip, even if you're not using the Regen Bioactive Endo Sealer, it'll work for the other bioceramic sealers, but in this case, I like the Regen Bioactive Endo Sealer. So I put the tip of the cannula down into the canal. I don't have to go down a working length. I can be a few millimeters, 4 millimeters even away from my working length. And then I backfill it. So I express the sealer out as I slowly withdraw the delivery needle. And so we'll have no voids, but as it comes up, I see a little puff of sealer at the orifice. Now at that point, I take my gutta percha that I had tried in already, so I knew radiographically it looked okay, and I place the gutta percha. And I do it slowly. I just let it slide down gently. The sealer is going to kind of grease that gutta percha, so many times it just goes in a little bit easier, and I just get it so it's nice and snug down the bottom. So I just use one gutta percha master point with the rest of the space being filled up with the sealer, and I go down and I place, in this case, the 3 gutta percha points. Now, the Regen Bioactive Endo Sealer will set in about an hour, so you don't have to wait too long, but I just get all my points in, and then I'll go ahead and take the PA. During this time, the sealer's setting. So then once I get my PA done and I've confirmed that I like the obturation, I can clean up the rest of the gutta percha and sealer, and then we'll go into the restorative phase. So the restorative phase at this point is the crown has been milled, it's been tried in and glazed. And so as I finish up the root canal, now we let the crown, as it comes out of the oven, cool. Then we have the peg material, so then we'll clean that out and air braid the integular surface. And then my assistant will etch the internal surface of this Emax crown with hydrofluoric acid, our porcelain etchant. Then I will go and clean out the chamber area of that tooth, make sure that our sealer and I gutta percha is all removed, and I'll try the crown on just to be sure that everything contacts and everything, even the occlusion looks looking good. Well, now I've contaminated the Emax, and not that it makes a big difference with Emax, but because I follow the same protocol, whether it be Emax or zirconia restoration, I take that crown out now. I treat it with ZRC, our zirconia cleanser, but it does any kind of material. Then I use the ZRP, our primer. Then I will have rinsed out the ZRC, but the ZRP we dry into our restoration. And then I can place a little adhesive on the internal of the restoration and then air thin that. Go back to the tooth. We etch with Velvet Etch. It's our 40% phosphoric acid that's purple in color, very easy to spread. and very easy to rinse off. So I really like velvet etch. But we put that in the chamber and around my crown prep. We rinse that off and then use the regen adhesive. I place that in the chamber again, in chamber space, and I place that on the outside walls of our crown prep. Then lightly thin that out with air. Now, what are we trying to do? The adhesive has solvents in it, so lightly hit it with air to evaporate off the solvent, and then with a little bit more vigorous air to thin it out, because I don't want it to be too thick. So light air for 5 to 10 seconds, and then just a really good blast of air for 5 or 10 seconds to thin it out. Then I cure that with my pink wave curing light. Remember, a pink wave curing light has 4 different wavelengths. It minimizes polymerization shrinkage stresses on the tooth, but it has that nice large head. So I'm doing a molar, and because the lens is over 12 millimeters in diameter, I just put that pink wave over the molar, cure that for about 20 seconds, and we're done. I don't have to do overlapping cures. Now we can use a dual cure resin cement like the Regen bulk fill cement, and the way we do this is my assistant will fill the crown up with the Regen bulk fill cement, and then put a little bit in the chamber area. That's kind of our buildup, and then we'll place the crown down. Again, using the pink wave curing light, but now with the little tack tip, we will go in and wipe off the excess, gross excess. Then I'll come up on typically the buccal margin, put that tacking tip, half of it on the tooth, half of it on my crown right at the margin, and I'll tack that restoration in place by curing it for 3 to 5 seconds. Now that crown's not going to move, but the rest of the cement has not cured. So now I floss the contacts, I wipe off all the excess cement, and then once I get it cleaned up, now I do my final cure with my pink wave curing light. So now I've cured that, and then I wipe off all the excess, but now the excess is going to be very thin, so I can kind of peel it off, and then we'll check the occlusion. So what we've been able to do is we have cemented this crown, the crown that was fabricated while we did the endodontic procedure, and in one visit we did the diagnosis, the endodontic treatment, and the restorative treatment. And as we mentioned before, this saves the patient a lot of time. They get everything done once, they get numbed up once, and so for them the comfort is higher, the convenience is much higher, and for us, instead of having to see the patient for the diagnosis, send the patient out, and then get the patient back for a crown prep, we get it all done. And so within about a 2-hour appointment, the patient gets everything that they need to have done, and that for many patients is just a great service. The patient's not going to have any kind of pain. They're numbed up once. They don't have to get multiple injections. They're happy campers. So I hope the presentation, I broke up into 2 parts so that it wouldn't be too long. I hope this presentation just shows you that in the coming year, if there's some skills you want to acquire, take the time to acquire them. Go to classes, listen to more of these YouTube videos where I'm trying to give you little tips. We've talked about aesthetics, we've talked about restorative, we've talked about endo, we've talked about occlusion, we've talked about practice management, we've talked about implants, we've talked about a lot of different things that we do in our practice. And again, as a fellow general dentist, if you've got comments, I'd love to hear them. If you've got tips where you can show me better ways of doing what I do today, I would love that. We are building a community of like-minded professionals, and I think that's the important thing to understand, is that we want to share information, we want to help you succeed. And the great part of dentistry today is that we can all practice in many different ways, provide many different services, the ones that we prefer to do, the ones that we like to do. We don't have to do everything. But I think something like a root canal, it's just very advantageous for us and for our patients when we can provide the endodontic procedure and the restorative procedure all at the same time. So if you like these videos, please hit subscribe. Send me some comments back. I would love to hear from those of you that are watching these programs. And you know what? I think it is time to get out of that gray zone and just enjoy practicing dentistry. I know I do every day, and I like to provide services that are good for me and my practice, for you, and for our patients. And if we can help you, and if this information has value to you, that's what we're trying to provide. So again, hit subscribe. If you think somebody might enjoy watching these programs, share. And I look forward to seeing you next time. Take care.